Welcome to Plastics in Practice. Today, we're doing a high-yield, no-fluff review of orbital floor fractures. This stuff comes up all the time, not just in the ER, but on your boards. So, we're going to cover exactly what you need to know, from the initial exam all the way to the OR. All right, here's the roadmap. We're going to start with the foundational anatomy, then move into the clinical workup. After that, we'll hit the really critical stuff, when you have to operate immediately. We'll cover our surgical options and then finish with a super important topic, the pediatric trapdoor fracture. Okay, let's dive right in with the fundamentals. You've got to have a solid grasp of the anatomy and the two classic injury mechanisms. Honestly, getting this down makes reading your CT scans and predicting outcomes way easier. So you've got two main theories here. Think of the buckling theory as a force hitting the rim and cracking the thin floor like an eggshell, usually smaller linear fractures. But the hydraulic theory, that's the classic fist or baseball to the eye. The pressure spikes and boom, the floor blows out. And here's the clinical pearl. That hydraulic mechanism is what gives you those big, nasty fractures with lots of herniation. The ones that are far more likely to cause that sunken-in look or enophthalmos that we need to fix. So, with that anatomy in mind, how do we evaluate these patients when they roll in? Your physical exam is everything here. You've really got to be a detective and systematically look for those subtle clues that point to a serious injury. All right, when you walk into the room, you're obviously going to see the bruising and the swelling, but you have to go deeper. Get your hands on the patient and feel for any bony step-offs. Check for numbness on their cheek from an injured V2 nerve, and then really look at the globe position. Is it sunken back? That's enophthalmos. Or has it dropped down, which is hypoglobus? And here's a great little pearl for you. You can actually start to see enophthalmos with as little as 2 millimeters of displacement. Okay, this next part is one of those things you absolutely, positively cannot skip. You have to assess the optic nerve, and the swinging flashlight test is your go-to move. You need to know how to do it, and more importantly, what a positive test really means. Now listen up, because this is a huge board prep question. You swing the light from the good eye to the bad eye. If that pupil, instead of constricting, actually dilates, that's a positive test. We call it a Marcus gun pupil, and it is a massive red flag. It means you've got a traumatic optic neuropathy, and that is a true ophthalmic emergency. You need to get ophthalmology on the phone stat. So after your exam, it's time for imaging. And the gold standard, no question about it, is a fine-cut coronal CT scan. And I mean fine cut. You need those 1 to 2 millimeter slices. Why? Because that's the only way you're going to be able to accurately measure the defect and, crucially, see if any muscle is getting pinched or entrapped in that fracture. All right, so here's the million-dollar question. You've got the CT, you've done the exam. When do you have to take this patient to the operating room? Right now. The indications are super specific, and you have to know them cold for your boards and for your practice. The first number to burn into your brain is 2 millimeters. If you see more than 2 millimeters of early enophthalmos, that globe is already sinking back. That's a strong indication for surgery. And the second magic number? 2 square centimeters. If the hole in the orbital floor is bigger than 2 square centimeters, you're pretty much guaranteeing that patient will develop delayed enophthalmos. And trust me, that's way harder to fix down the road. So let's just put it all together. Here are your absolute take to the OR within 48 hours indications. If you've got big enophthalmos, a big defect, or diplopia with clear muscle entrapment on the CT, you operate. And then there are 2 emergencies: a non-resolving oculocardiac reflex, where the patient is bradycardic and nauseous, and any pediatric trapdoor fracture. These are no-brainers. Okay, so you've made the call to operate. Now what? Well, you've got 2 big decisions to make. How are you going to get there? And what are you going to use to fix the floor? For your approach, the trend these days is definitely toward transconjunctival and subtarsal incisions. The subciliary, people don't do that much anymore, and for good reason. The risk of pulling down the eyelid is just too high. The transconjunctival approach is awesome because it leaves no visible scar. And the subtarsal gives you great, direct access and has the lowest revision rate. Now, for what you're going to use to patch that hole. Look, there's no single perfect answer. It's all about trade-offs. Using the patient's own bone is the gold standard, but then you've got a donor site. On the other hand, permanent implants like titanium mesh or porous polyethylene are super convenient and strong, but they carry a tiny risk of infection. In reality, these modern alloplasts are used all the time with fantastic results. Okay, this next point is absolutely non-negotiable. This is the last thing you do before you close. You have to do a force deduction test. You grab the muscle insertion, you move the eyeball up and down, and you make sure it's totally free. The last thing in the world you want is to fix a fracture just to accidentally trap the muscle with your own implant. You gotta check every single time. All right, let's shift gears completely and talk about kids, because honestly, this is a whole different animal. The presentation, the management, the urgency, the rules really do change when your patient is a child. You have to be paranoid about the white-eyed blowout. Why? Because the kid might not look that bad. They might have a totally white, quiet eye with very little bruising. But because the oculocardiac reflex is so strong in kids, they might just present with nausea and vomiting. It's so easy to miss that what's really going on is a green stick fracture that has snapped shut on the inferior rectus muscle. It's a true surgical emergency in disguise. So here's the bottom line. For kids, you don't wait. Forget what I said about waiting for swelling to go down in adults. In a child, if there is any sign, clinical or on the CT, that a muscle is entrapped, the clock is ticking. You have to get them to the OR within 48 hours to prevent that muscle from dying. And this different mindset extends to your implant choice. A kid's face is still growing, right? So you can't just put a permanent titanium plate in there. It'll act like a tether and restrict the normal growth of their face. The standard of care here is to use something that will go away, either a resorbable plate or a piece of their own cartilage or bone. So if you take away one single thing about pediatric trapdoor fractures, what is it? What's the number one factor that's going to determine if that kid has double vision for the rest of their life? The answer is simple. It's time. Period. The longer that muscle stays trapped and ischemic, the higher the chance of fibrosis and permanent damage. The take-home message is crystal clear. Don't wait.